Anybody? No? Are you sure, Jan? You are shaking your head one way to other? Right. Item 3, minute of the meeting held on 11th of March, 9th of June, 2nd of September. Everybody read those minutes? Any matter arising? No? All in favor of those minutes? Thank you. Silence means that everybody's okay. Public question? I don't have any. Item 5 is COVID-19 vaccine update.
So reports in the media of the effectiveness of a number of vaccines in recent weeks has been a great boost to everybody's morale. And this morning we had news that the first vaccine has been granted regulatory approval, and the first few thousand doses should be arriving in the country in a matter of days. We know that the vaccine is effective in reducing the illness in individuals who are exposed and the severity of illness in people who have COVID despite vaccination. But what we don't know, and we won't know until the vaccine is deployed, is how effective it is at stopping transmission between people and helping us to return to some degree of normality. So we do need to manage expectations. We need people to stick to the current restrictions that are in place at the time, and hands, face and space will continue to be the watchwords until effective population herd immunity has been demonstrated, which isn't likely until the late spring, early summer. Next slide, please. So the Joint Committee on Vaccination and Immunisation, the JCVI, has published draft priority recommendations. The latest version was published on the 25th of September, and the highest priority groups are older adults resident in care homes and care home workers, all those aged 80 plus, and frontline health and social care workers. Now that the first vaccine has been approved by the MHRA, the JCVI will review and finalise their priority recommendations, but we don't expect it to change significantly. Next slide. So these are the two vaccines that are expected to be available in quantity soon, with the Pfizer vaccine having gained a regulatory approval. That will be the first. It must be stored at a very low temperature, minus 70 degrees centigrade, which will constrain the distribution and the delivery model and is the basis of current planning. The government has purchased 40 million doses. Both of the vaccines shown here require 2 doses to get maximum immunity, so 40 million doses equates to up to 20 million people, but we will expect some degree of vaccine wastage, aiming for less than 5%. The Oxford vaccine will be much more portable, and because of its less stringent storage requirements, and a larger quantity has been ordered. Next slide, please. So it's worth saying something about the novel technique that has been used to develop the Pfizer vaccine. It's what's called an RNA vaccine. It uses synthetic RNA technology with no virus used in its manufacture. In the long run, these will be relatively quicker and less expensive to make and may well be safer to use. Viruses work by invading host cells and getting the infected cells to use the viral genetic code to make more of the virus. And RNA vaccines use a small portion of manufactured viral genetic code that's been specially prepared so that it gets into human cells easily. And once inside the cell, the RNA codes for the production of a viral protein, the spike protein, that generates a strong immune response in the host, which provides lasting protection in the event of real infection by the COVID-19 virus itself. Okay, I will pass over to next slide, pass over to Catherine at this stage.
Thank you, Gifford. So from a CCG perspective, the initial ask that we were given was that we worked with and supported our primary care network and GP colleagues to establish sites that were available and ready to start vaccinating from the 1st of December. As Gifford has just explained, the first vaccine was approved last night. So I think this presentation does come with a slight health warning that this agenda is changing very rapidly and new guidance is coming rapidly and things are moving. So as of the position today, we have been told we've got a 10-day window to when we will receive those vaccines. So within the PCN sites, and apologies, some of this information I won't flow during this, we have 8 sites across the Pennine, Lancashire footprint, which will deliver on behalf of the PCNs. And the cohort, as Gifford has said, are the over 80s, the residents in care homes and residential homes and health and social care staff in the first instance. We are not expecting that to change. And at this point in time, we are not expecting those sites to receive the Pfizer vaccine that has been approved. And that's because of the storage of that vaccine. That -70, -80 doesn't lend itself to being stored in the health centres. It is something that needs to be stored in different places. So we are on a 10-day notification. The AstraZeneca or Oxford vaccine is expected to be about 2 weeks behind the Pfizer vaccine. So we sit and we wait until we hear that we are going to get that. What we're doing in the meantime is we are working with those sites. So for each of those sites, there's a site manager who is working with CCG team now to look at all the operational elements of that. And both yourselves, the local authorities and borough councils at the other end of the patch are working with us in terms of highways, signage, marshalling, winter plans, etc. And that is very much appreciated. So we're in a good position with our estate. We've got some good buildings and we've got an element where we can ensure that these sites are COVID safe. So that's the work that is currently in place. And I feel very assured at the moment that we will be ready to deliver as soon as we get that call to say vaccine is on the way. The national ask is that sites will be open 12 hours a day, 7 days a week. So 8 till 8, including bank holidays. Now, what that might mean is that vaccination isn't given 12 hours a day. The vaccination might be given between a single shift, an 8-hour period, but somebody would be in that building to receive that vaccine if it were to be delivered either at 8 o'clock in the morning or 8 o'clock at night. As Gifford has said, there is a time lag. So these vaccines, all of them, even those that aren't approved, are a 2-dose vaccine. So the first one, the Pfizer one, is 21 days. So 21 days or plus that patient needs to have a second vaccine. And the Oxford one is 28 days or 28 days plus, as they're saying today. We do need to ensure that people come back for the second vaccination. That is important. As you'll be aware at the moment, there is a big push for all those people that haven't currently had a flu vaccine in the age group that are 50 plus up to 64 that haven't been eligible under previous schemes, go and get that vaccination. There is currently an assumption that there will have to be a lag of at least 7 days from having a flu vac to having a COVID vaccination. So we do need to look at that, and we are pushing that through comms. And what some sites are doing now, and some GPs, is using this window where they're vaccination ready to test some of the protocols using flu rather than COVID. And that is a fantastic idea to do that if that's possible. We are looking at workforce because obviously workforce is going to be key, and we are looking at consent, and that includes both best interest elements of consent and mental capacity. This is a new vaccine, so we haven't got all that history in terms of knowing about the vaccine. You can't say to somebody, have you previously had an anaphylaxis reaction to this vaccine, because nobody's had it. So that process will take slightly longer. There will be some national work done on that, but we've done a lot of work across the ICS to make sure that we've got consistency and that the same questions will be asked around that clinical assessment. When you have a flu vaccination as well, you could have that vaccination from a non-registered member of staff who've been trained, and there is a piece of paper, a PGD, that is a patient group directive, which actually states that person can do it. It's kind of an instruction. With this vaccine, because it's new, we need another PGD, and that has to be done nationally. So again, they're working to ensure that we've got that. So there's lots and lots of work going on in the background to ensure that we're ready and able to do this. Can I have the next slide, please? So apologies, some of this won't make sense because I was going to take you through the sites, but these are all the sites. You can see Blackburn with Darwen there. And what we're doing from the current GP systems is trying to model the numbers that we have. So the total populations, both in care homes and the over 80s, there will be some duplication there, and then work out what our workforce needs to be. Sorry, can I have the next slide, please? Thank you. So there's lots of modelling happening, and we're looking not just at the cohort that's currently being asked, but we're looking at further cohorts as well, because this is going to be a very rapid vaccination programme. And one of the calls I was on today was very much, if you have vaccine left over, and as Gifford said, we don't want to waste this vaccine, and the patient stood in front of you is 79 and not 80, it would be in the best interest of them and us to vaccinate. So we are going to try and use this vaccine as quickly as possible and have a very quick throughput for that. There are some general principles here in terms of how that's designed. And again, this doesn't make sense because the slides have gone that showed the pods. And that's just really a vaccination place where that vaccination will happen. But nationally, they've come out and said the pods have to meet a certain criteria. So they have to be self-sufficient. The vaccine has to be there. We have to remember we're vaccinating for COVID, that social distancing, hand washing, covering masks is very important. We need to ensure that is all deployed through these areas. So we have a safe space and people feel comfortable and confident to go into that space. So I won't go through some of that because it doesn't make sense in relation to the previous slides going. If you want to move on. There is a flow, so we are working from the car park all the way through the journey of that patient coming into a health centre or into a practice to go through their vaccine. We are looking at one-way systems, we're looking at all the infection prevention, and we're testing that out. One of the asks is around marshals, and I've had conversations on other meetings around can we go out to contract for people that perhaps have security backgrounds, etc., that we could use. We will need more marshals than others on some places and some of the sites, because we do have testing centres that are quite close, and clearly we don't want those two cohorts of patients coming into contact with each other. So we've got national guidance on what we need to do, and we are following all of that. So again, that's the journey. The next slide will be missing, which would show you a building with a journey in it, but we are following that. So if we go to the next slide, please. So this is some of the workforce summary. So again, in relation to the numbers, we've got some national guidance on what we might need, and that depends on the population, how big the site is, how many vaccination pods we're going to have. And this has changed as well since we first received it. Initially, when the guidance came out, it was saying that after every individual has been vaccinated, we had to have eyes on them for 15 minutes post-vaccine. Well, that has now gone, so that doesn't have to happen. What we would do is give people advice in terms of please don't drive for the next 15 minutes if you're driving yourself. But that does decrease staffing, because that means we can decrease that clinical member of staff that we need in there. So we've got general guidance on staffing, but we're working very specifically now with sites, with PCNs, with GPs and with yourselves around what we actually need for each of those sites. Have the next slide, please. Again, that's just a workforce summary around the pods. So if we take the next slide, please. And again, this is a breakdown of some of the demographics that we've got. And you can see there, we've got Blackburn, East, North, West and Darwen, and we've got those totals. So we're sharing all of this, and this is coming from the systems that we currently have. And a lot of these groups are based as well around the flu and the eligibility criteria for flu, which has been established and is well known. So that is very helpful. Next slide, please. Again, just further modelling on that proposed site, and that's the numbers in care homes and residential homes. So the expectation in the homes, again, keeping footfall low, is that if, say, 2 members of staff go into one of the larger homes to vaccinate, they will vaccinate everybody in there, including staff, at the same time. So we want as many people vaccinated at that point in time. That reduces waste, and it also makes it more convenient for people to have the vaccination. So that is the expectation. Next one, please. Again, it's more modelling. Next one, please. We have got a governance structure around all of this. As you can imagine, this has been updated since it was first put together, but this does report all the way up through the LRF and into the ICS. We can't forget we are in a command and control situation, so we do expect and are having regular daily conversations at this point in time around vaccination. We do have an expectation that when we start to vaccinate, there will be a daily return into the centre, both in terms of the numbers of vaccines that have been offered and those that have been accepted. So I don't know what that looks like at this point in time, but that is the expectation. We have a local operational cell, which meets 3 times a week on a Monday, Wednesday and Friday. And we have a programme board that meets on a Friday afternoon. So there are escalation routes, and we also have those site-specific operational groups, which are escalating into the 3 times a week meeting. So there is quite a tight process around all of this. The next slide, please. So this just takes you through really what that programme board does, and the next slide is the operational cell that is happening. So that's the current position that we're in, and I'm happy to take any questions.
Thank you very much, Catherine and Gifford. Any question, comments, anybody? Put your hands up, Ray. I can. Anybody question, comments? No?
Mohammed, sorry, it's Dominic here. I've lost my hand somewhere.
I lost my hand. There is no hand here on my screen.
No, someone stole my hand. But I'd just like to ask for clarification, because it will be asked, I think, across our communities. And I just want to check really with Catherine and Gifford that this is correct. At the moment, as far as we know, neither the Pfizer vaccine nor the Oxford vaccine, neither of them are carried on porcine gelatin. Is that correct?
Yes, that's my understanding. And also it was confirmed today, Gifford, that they are saying no egg-based product either is in there.
Right, brilliant. That's great. Thanks very much.
But we need the we haven't received the MRHA list of what it contains yet, but that is what people are saying.
Great.
Anybody else?
Mohammed,
Yes.
can I ask about workforce, Catherine? So you're drawing on the PCNs. Will that give you sufficient resilience with regard to the vaccine sites, as well as doing really this outreach and targeted work that you're going to need to do in care homes? That seems quite onerous, to be honest. I just wanted to ask you.
The workforce is always going to be difficult, Jane. I think that's an underlying assumption. It will be tough. The PCN sites at the moment for that cohort, I think we'll manage across, and it's the ICS who will be managing and staffing the mass vaccine sites. So they're coming from the mass vaccine sites as it stands now, is that those people will be people who volunteered, so retired, those people that work part-time. They're coming off that register that was set up at the beginning of March, but I'm under no illusion that they will come and ask for help for those sites. And my worry is around pharmacists, really, because of the complexity of the vaccine, that recording and those batch numbers. You know, we can train people to vaccinate, but that skill set around pharmacy, and we will have to at some point go out to community pharmacists.
Thank you, Catherine. That's sorry, Mohammed. That's really helpful. Thank you.
You're welcome.
Okay. Anybody else? No? Everybody happy with the presentation? Thank you, Catherine. Catherine Gifford. Thanks a lot. Next item is item 6. Situational awareness. I think Dom and Ken are doing the presentation. Who is first?
Thank you, Mohammed. I think Ken is going to share his screen, and then I'll make some comments at the end of Ken's presentation. You may be on mute, Ken.
Right. Yeah, okay. Yes, I've just got a few slides to present to you. Just really provides a summary of the pandemic to date. And as we all know, this has been a long haul. We're now into week 39 since the initial lockdown was announced on the 23rd of March. And the first graphic just shows the progress of the pandemic through the country from the start of January, when there were no cases, the first wave, and then into the second wave now, which started round about just before the start of September. And one of the things really to note about this is that in the early days, in the first wave of the pandemic, we were only testing people really in hospital. So hence the peak is much lower, but clearly those people who were in hospitalizations were much more serious cases than all the positive tests we have now. But what we can see is the pandemic reaching its peak in the second wave around about the 11th of November or so, and then starting to reduce following the lockdown. Okay. Yeah, and this is again just a reminder of the national situation that we're in. The two graphics here show the case rates per 100,000 population. On the left, the weekly case rate, and on the right, the fortnightly case rate. So the darker the colour, the greater that case level. And as we can see on the fortnightly case rate, much of those darker areas are concentrated in the north, as we know, other than this area of Kent here, with Swale and Thanet. And other places, which is causing great consternation for some of the other parts of Kent, where the rates are actually quite low. But that concentration in the north, we've kind of got Greater Manchester here, and then Lancashire, sorry, the Midlands here, and Lancashire here, Blackburn with Darwen here. And then just to look at the Lancashire picture, this is taken from the Northwest sit rep and shows some of the key indicators that we're looking at in terms of developing policy and strategy nationally to identify tier 1, tier 2 and tier 3. So this graphic, and I've read the guidance for the winter proposals quite clearly, shows most of the key indicators that are being used to determine which tier you go into. So that's the positivity rate, and you see that our rate is 11.3 and currently coming down. The case rate per 100,000, our rate is 281.9 and coming down. The case rate specifically for people aged 60 plus, because as we know, for older people, the risk is much, much greater of hospitalisation and mortality. And then also the case rate for younger people aged 17 to 21, because the analytics that we've done suggest that those younger people are kind of the starting point of transmission in households. So those are some of the key factors, and along with that, the pressures on the NHS. So I'll come to that later. But looking across the northwest, then this is showing the heat map of the confirmed case rates by age group, 0 to 15, 16, 29, 30, 44, and so on up to 60. And this kind of shows how the case rates are coming down across those age groups. So in 60 plus across the northwest, from 325 down to 141, and then there seems to be a concentration then in the 16 to 59 age group. So that's the northwest picture. So this is all on the same scale, with the darkest at 800 plus, which shows up black. But in Blackburn with Darwen, based on the evidence that we've had nationally and some of our own local analysis, there's 4 kind of key areas of risk factors. First of all is deprivation. And yet, as we know, Blackburn with Darwen has high levels of deprivation. Almost 2/3 of our population are amongst the most 30% most deprived nationally. And 3 out of 4 positive cases are located in those areas. So there are concentrations in those areas of cases, as we might expect. Occupation is another key risk factor. And we also know that Blackburn with Darwen is a low pay economy with average wages less than the regional average. So some of the occupations that are highest risk are those occupations which are most prominent in Blackburn with Darwen. Household overcrowding is also a key risk factor. So high household numbers in small houses, and that's a driver of household transmission. So we're identifying now case studies with intergenerational transmission, where a school age or a college age pupil was the first household index case, with 4, 5, 6 more positive cases in that same household. And as we know from the National Research, demography is also, an ethnicity in particular, is a driver and a key risk factor, particularly South Asian heritage. And Public Health England analysis showed that even after allowing for age, gender, deprivation and region, Indian, Pakistani and other South Asian groups are between 10 and 50% higher risk of mortality compared with white British. So that's national research, but certainly that applies in our patch. Now coming back to our most recent figures then, these are the current bang up to date figures for Blackburn with Darwen. The graphic in the top left hand corner shows, the blue line shows the number of weekly cases in the week prior to the date. So the most recent date is the 27th of November. So in the week running up to the 27th of November, we had 442 cases, which shows a case rate of 295 per 100,000 and 73 cases on that particular day. The graphic in the bottom left hand corner just shows the numbers of cases, confirmed daily cases. The 4 final bars are shown greyed out because though the data for those dates are not yet complete. So the general rule is that the 4 most recent days, it's not complete data up to the 21st. Then another key factor is our testing rate. So we've had a lot of testing activity across Blackburn with Darwen. We had up to 5 testing sites at one point. We don't now, we have 3. We have the hospital, major regional testing site, and we have 2 local testing sites, one in Blackburn and one in Darwen. And our testing rate was as high as well over 500 per 100,000 population per day. In the most recent days that has come down, but it's just showing signs of turning back up again. And clearly when we start to implement the lateral flow testing, those testing rates will go up significantly. We know that in Liverpool, when they implemented lateral flow testing with their huge on-street army testing regime, their testing rates went up over 2,000 per 100,000 per day. And that actually for Liverpool had a huge impact on the positivity rate, because the positivity rate for asymptomatic testing is more like around about 0.5%, whereas our current testing rate is 11.3%. So that's 11.3% of all tests that are done are showing up as positive over the course of the week up to the 27th of the 11th. So again, that positivity rate has come down. The middle of November, that was at 18%. Prior to that, early in November, it was up as high as 22%. It's now down to 11%. So that's halved over the course of the month. Then coming on to our own heat map, we can see that the intensity is much more significant in Blackburn with Darwen than it was across the northwest. We had rates as high as well over 1,000 for 16 to 29-year-olds, approaching 1,000 for 30 to 44-year-olds, and over 800 for 45 to 64-year-olds. The good news is that, as in the general figures, the rates across age groups are also coming down, particularly this rate in the 65 plus, which has come down from almost 600 to down approaching 200. But we can see from the earlier heat maps that intergenerational transmission, and this is our kind of theoretical way of thinking about transmission, that you can see that transmission sweeping up the age groups, starting off in younger age groups, but more generally in the 16 to 29s and gradually going upwards. So we see this, the first graphic on the left shows from the middle of September, and the second graphic on the right shows from the start of October through to almost the end of October, and you see that intergenerational sweep. And then coming back to the current data, just making sure that we're aware of that other risk factor, which is ethnicity. So we see here that over time, the percentage of our Pakistani community that have been affected by COVID has stayed roughly the same, at around about 1/4 of all positive tests where the ethnicity was known. And about half of those positive tests were for our people of white heritage. And Indian heritage comprised round about 1 in 5, 20%, although that has come down in the most recent weeks. And then in terms of age groups, we see that that has increased, particularly in that 65 plus, from 11% through to the most current week at 16% of all positive cases. And we see that coming through into the hospitality mortality as well. Another area that I wanted just to look at very, very briefly is the breakdown across the various different locations in Blackburn and Darwen, so across our wards. And it is again really encouraging to see that in some of those wards where at the height of wave 2 in Blackburn and Darwen, where places like Bastwell, Audley, Blackburn South and Lower Darwen, and particularly Sheer Brown Corporation Park, the rates in those wards have come down significantly over that time. The areas where it says there's a decrease in green shows that there's a significant decrease week on week. So those areas were up as high as over 1,000 per 100,000 in that particular ward, particularly places like Audley and Greens Park. At one time the rate there was over 1,000. Bastwell and Daisyfield, Sheer Brown Corporation Park. These were well over 1,000 and they're coming down significantly. So it's not just a general effect across the borough, it is geographically located as well. And the final thing that I wanted to show in terms of those key risk factors is deprivation. We've done some analysis in relation to deprivation. What the graphic on the right shows, with underneath the graphic it's showing 1, 2, 3, 4 up to 10. Those are the 10 national deciles of deprivation, where 10 is the least deprived and 1 is the most deprived. So this the case rate in our most deprived area was 5,082 per 100,000, and that's across the start of the whole pandemic. But what we do notice is that for the third most deprived decile, the case rate is the highest. And we do see a clear difference between the first 3 deciles, where it's 5,000, 6,000, 7,000, compared with the most relatively affluent deciles, where we've got 4,000, 4,000, and we don't have any cases in our one low super output area that's in the most relatively affluent decile nationally. And that shows clearly when you look at all local authorities. So the graphic on the left shows all local authorities, their level of deprivation across the bottom axis, and their case rate per 100,000 since the start of the pandemic on the upward axis. And what it shows is that Blackburn with Darwen at this point, which was up to the 6th of November, was a clear outlier. So in terms of the general trend, which is this dotted line here, the general relationship between deprivation and cases, Blackburn with Darwen was significantly higher in terms of our overall case rate than any other local authority in the country. And we see that even compared with statistical neighbours, which are amongst the most deprived in the country, Manchester, Middlesbrough, Hull, Stoke-on-Trent and so on and so forth, our case rates were the highest. And that's much of that is to do with the point at which Blackburn with Darwen hit the second wave, and our case rates increased significantly, but they're on the way back down now. And then finally, as I was saying earlier, the final factor that government are looking at is the impacts on our secondary care system, impact on the health sector. So we monitor this daily, and the table in front of you shows the numbers for each day for the last week, from the 25th of November through to the 1st of December, showing the number of COVID patient admissions in the last 24 hours. So those go 719 and so on and so forth. The number of inpatients confirmed with COVID. So some of those may have developed and tested positive subsequent to admission. The number of suspected COVID patients. So this is inpatients where a clinician has identified them as having symptoms where they require a test, but the test hasn't come back yet. And then finally, the current number of inpatients. So started on the 25th at 242 and now has come down to 207. And by way of context, at the height of the pandemic in the first wave, the highest bed occupancy with COVID patients was, I think it was 128. So with far more patients in now, and certainly over the past month, mortality has increased significantly. So as we can see there, over the past week, we've had 38 cases. Sorry, my arithmetic's let me down. 605 minus 568. So mortality is quite significant, and these are predominantly patients at high risk in terms of age. And then the final graphic that I wanted to show you is the progression of COVID deaths since January. So what this graphic shows you is this is the number of deaths in Blackburn with Darwen in each week since the 6th of March. The bars in yellow show non-COVID deaths, and the bars in red show COVID deaths. So we see quite clearly the higher number of COVID deaths from the week of the 3rd of April through to the week of the 29th of May. The black dotted line shows the average number of deaths in each year between, and so it's a weekly average for the previous 5 years, so that's 2015 through 2019. So from this you can get an idea of excess deaths throughout the year. So when the COVID pandemic struck first wave, significantly higher than the average, then it settled down, but now then since round about the 3rd week in September, the number of deaths has exceeded the average. So on that note, that's the end of the presentation, and I'm happy to take questions and hand over to Dom for the rest of the situational awareness.
Thank you very much, Ken. Thanks a lot. Dom?
Yep, thanks, Ken. I'll just add a few comments, really in relation to the tiering system and what our prospects might be over the next few months. So I think one of the things Ken showed was, although we have gone down faster than the national average during the lockdown, everywhere went down, except Kent, worryingly. I don't know what position you might be in if you've been going up during the national lockdown, where you might get to afterwards, but almost everywhere in the country has been reducing its rates. Lancashire and in particular Blackburn with Darwen reducing faster than the national average. At the beginning of this week, we had reduced by, compared to the previous week, we'd reduced 37% in terms of our cases. But in the last couple of days, we are just seeing that little rise again. And that is happening across, despite the fact we only just exited the lockdown today. That rise is being noticed in a number of areas in Lancashire. So, for instance, Lancaster, which had one of the lowest rates, has just gone up 6% in the last 2 days. No one's quite sure why. We could probably speculate what that might be about. Possibly people getting fed up of the lockdown and seeing the end of it and not keeping to the rules. We don't know though. But we now have 4 weeks or 3.5 weeks to go into Christmas, and at Christmas we'll have 5 days of complete relaxation of the almost complete relaxation of social mixing guidance in houses where 3 families can get together in a single house over a period of 5 days. They have to stay in that bubble, of course, of those same 3 families. What we expect that to do to our data is, I think we might inherit at least a plateauing or a very slow rise up until the week before Christmas in our data. Then probably the week before Christmas we won't be getting any more lockdown effect, suppression effect, and of course we'll have also had everybody going to the sales and the pre-Christmas shopping and all that sort of thing. So we will get more social interaction. The rates will go up. They could go up quite quickly. When we get to the 5 days of social mixing, we'll get an explosion of cases. And we will get more than the national average for various reasons to do with those 4 drivers that Ken showed before. We're more at risk, we have more chance of the rates going up faster, particularly the household occupancy issue. but also people bring into that situation a higher risk from frontline work. And we have more people at risk because of multi-generational households. So we are going to get a big hit, which will probably be visible in the data by the second week of January as a big surge in cases. And by that second or third week of January, that will translate into rising hospital admission. And what we're probably going to see, we think, is basically a third wave for high risk areas, possibly even the country, that will rise in the second, third week of January and peak sometime mid to late February. So we need to get ready for that. But one of the consequences in terms of the tier 3 issue is that it seems very unlikely in the light of that we will get down to the levels at which you would exit tier 3 and go into tier 2, in my view, anytime before the end of March. There are some positive bits, which we're talking about later. We're doing some mass testing as part of the tier 3 agreement with central government, and we've got probably more going on for Blackburn with Darwen than other areas, because we're doing a special piece of work with schools. So that will hopefully help us to contain some of that risk, but I don't think it will get rid of the risk. So I think we are in for a long run of tier 3 level controls in the borough. We're all doing the best we can with as much resources we can get to contain the risk, but I think we have to be realistic about where we are and what the drivers are of our risk that are not amenable to short-term fixes. And I think the slide Ken's showing now is really part of our story. Those risks for us are structural risks. However well behaved and compliant the population is, if you have those 4 things together, particularly, you get a compound effect of higher rates. And I think you can see that in the data with other areas like Oldham and, you know, other areas in the northwest. So we are doing our best, but we probably have a steeper hill to climb than almost any other local authority. We do have the highest cumulative case rate of any local authority in the UK. So in other words, we've had more cases as a percentage of our population than anywhere else in the UK since the beginning of the pandemic. But we have a history in the borough of being kind of high challenge, high response. So, and you should never be certain about anything in this pandemic, but I'm giving you my best guess on where we might be over the next 3 months. But everybody's doing a great job, and if it had to happen anywhere, Blackburn with Darwen's one of the best places, because we'll give it the best shot to get out of tier 3 as soon as possible. Thank you.
Great, Dom. I hope we will be out after Christmas. Right, any question or comment to Ken and Dom? Anybody?
Saeed's
Yeah.
got his, yep.
Yeah, Chair, it's a bit tricky without those electronic hands.
Yeah,
So
you're
we're having
right.
to
I
resort
can't
to
see
our-
the people. Yeah.
Our proper hands. There's a few points really. First and foremost, I think I've just been in a meeting earlier where we were discussing some of the impact on special groups, if I can call them that. And I'm particularly concerned for us to ensure that we have data around how COVID has impacted on people with learning disability, autism, and you know, I'm not sure how we get it, but people who perhaps have already had known underlying conditions, because it does seem to be a feature of COVID-19 that these people have disproportionately been impacted along with the Black and minority ethnic communities. So we do need to note that concern. There are obligations upon local authorities with our partners to have specific care plans for people with learning disability and autism and disability. And I am picking up a lot of concerns across Lancashire about inconsistencies in terms of the way in which those care plans have been delivered. So they're not specifically to do with adult social care or children's services, but a feature of primary care in terms of the care that's required for these people. So I think for us, it would be useful for us to perhaps do a specific piece of work on those specialist groups and to ensure that we are cited on the challenges those special groups have faced, and that we're doing things which will mitigate or support them through these difficult times. The other point I wanted to make, Chair, was around the COVID symptoms. So yesterday I had a message from a friend regarding a colleague of mine who I went to school with in the same year group as me, and post-COVID, he had COVID in May, and then he suffered really bad health until he passed away yesterday. And it just highlights that there's something about early intervention after somebody has contracted COVID. And you know, there's a lot been said about long COVID and post-acute COVID syndrome or PACS. And I do feel as a local authority and as a health and wellbeing board that we have a duty to look at this in terms of a system response, to be early and to be able to work with people the moment that they've been traced and have been known to have COVID. Otherwise, we're facing a very significant problem in terms of increased morbidity, but also significant increases in people's well-being over the longer term, which will directly impact on the local authority's ability to meet those increasing demands, particularly for adult social care, but not least for children's services as well. Because if you assume that some of those people are parents, then it does expose their children to risks as well. So I think we need to be positive about that. And I think equally, as much as Dominic is the bearer of bad news, often, and sadly it's his job to tell us that as it is, we need to look at how we engage with our communities on a positive perspective to actually say that there is another scenario here, and that is that the community takes COVID very seriously and works with us with hearts and minds to ensure that the impact of COVID is not going to be beyond March, even if it's beyond Christmas. I think it's a wretched time for our communities, and therefore we need to do that hearts and minds, Chair. Otherwise, it's going to be a very long, drawn-out winter, this, and we need to get some of these things on a proper footing. Thank you, Chair.
Thank you very much, Saab.
Chair?
Yes, sir.
Chair, thank you. I agree with Syed's comments there, and I think some of the work in the COVID virtual ward that accepts patients from discharge and step up from primary care will help in that, with the risk stratification of patients that goes on with it. I suppose this afternoon, in terms of hospital admissions and positive cases in the hospital, it did drop to 191, which is under that 200 barrier, which is really positive. But I suppose we've been talking about the direct impact of COVID, and we've got to remember the indirect impact of COVID as well, with the years of life lost with people who've not been accessing services, and also the mental health of our residents and the impact of services that they need to support them, with admissions going up and access to community services even more important than they were before. So I'll just comment on that. Thank you, Chair.
Thank you very much. Julie Gunn.
Thanks, Chair. Just a couple of questions, if that's all right. In terms of the prospect of, because of all the good work that we've had demonstrated tonight is at risk of being lost because of the opening up of the economy again and the Christmas break from lockdown, if you will. I'm just wondering, in terms of how we communicate that message about we're almost there, keep going, we need to keep you know, we need to keep strong on that. I'm also aware that during the first lockdown, there was much more, for want of a better word, crowd control in shops in terms of the numbers of people allowed to go into the shop and those kind of things. And I haven't seen any guidance on that. I don't know whether there is yet, about how we, you know, the potential for crowd control needing to be in place for, you know, the run up to Christmas, but specifically after Christmas during the sales. I think that is something that I don't know whether we've got anything in place for that. So that's one question. The other question is related to the vaccine, and I'm sorry I'm a bit late in asking this, but the period between the 21 days or 28 days, when it's a two-part vaccine like that, does that mean that there's a risk that people won't turn up for the second? I'm hoping that that's not the case, but is there a risk? And how immediate then is the protection after the second dose? And can we, you know, we need to communicate that as well. And my other question is about the timeline for the vaccination programme that we've got for schools, but I think Dominic said you're going to mention that anyway, so that perhaps can be picked up later. Thank you.
Okay, Tom, are you going to respond?
Yeah, should I have a go at those? Gifford might want to come in on the vaccine one, but in terms of the comms, we are going to do just before Christmas a lot of comms on how to reduce risks in household settings to try and manage some of those, you know, that 5-day Christmas risk. So we have got some plans for both for Be With D and across Lancashire on that issue. So, and there is Sage produced some guidance on what the evidence base says would work to reduce risks in households, which of course is useful for us more generally, but particularly at Christmas. So we will be putting that out, and there's a kind of 10-point plan they've suggested that people institute in their homes, which doesn't involve putting granny in a hazmat suit in the corner, so which is good news. So that's that one. On the crowd control, yeah, I mean, obviously Blackburn has been extremely busy today with potential savings from shopping at Debenhams, but also, you know, because it's the first day that it's been open since for 4 weeks. So we have got COVID marshals. The MAL has got marshals employed as well. We will keep this under review. We have also got some new powers in the new coronavirus guidance. So we have powers to shut down any premises that is not compliant with COVID safety, either workplaces or you know, shops or other venues. And those powers have been strengthened as part of the Tier 3 agreement. So we are looking at how we might want to use some of those. But obviously what we're trying to do is get cooperation from everybody. And on the vaccine, I think, as I understand it, in terms of how long, you do have to have both doses to get the 90% immunity. But the immunity isn't the moment you've had the jab, and I think Gifford might come in, but you do need, I think, between 3 and 5 weeks before the maximum immunity is achieved from that vaccination. So there's a number of weeks anyway, and you do have to have both doses. And what we know from other vaccinations where there's 2-dose schedules is you do get a drop off between the first dose and the second dose. People think they get bored, or they don't want to come back, or the first one hurt them too much, variations on that, or they just miss it, you know, which means you have to chase them, which can be very time consuming. And I think that is why, I mean, you might have heard Matt Hancock saying, oh, we'll have everybody done by the end of April. I don't know anybody in the system with any experience of running such a program that believes that for 1 minute. I think we'll be lucky to get through the main at-risk groups for herd immunity by June, and probably somewhere between June and August before we get everybody done, because, you know, there's so many things that are operationally difficult to ensure run like clockwork in this. Yeah.
Okay. I think Don, Vicky Shepard put this on the chat. We also need some planning around these supporting people with additional need to access the vaccine. And I think that's what my concern. There are a number of people with long-term condition
Yeah.
My wife is COPD. She never seen the daylight for 9 months. And I think we need to think about it, how we are going to protect those people who are housebound for the last 9 months. And I think just going a residential home are probably targeting 80 plus. And I think we have to look at it, where is the bigger risk, and try to save the life of the people.
Yeah.
Vicky?
Thanks, Chair. I guess it was picking up on that, on the comment that Dom's just made about that. We know there's a risk of people not going back for their second vaccination, and I think for me there's something around collectively trying to plan what kind of comms and support we can put in across the system. So what should my staff be saying to people when they're having conversations around encouraging people to go back for their second vaccination? So I think we've got some community assets that we could employ around encouraging and supporting that, but it needs a joint planning approach to it, alongside the logistics of the kind of actually administering the vaccine. So I think it would be good to have a conversation collectively or with relevant partners about how we can all support that.
Thank you.
Thanks, Vicky. Yeah, really good points, and I will pick those up and come back to you. Yeah.
Thank you. Anybody else? Question to Dom or Ken? No. Can we move on to item 7?
Sorry, just on that one. Vicky,
Sorry,
we have the weekly comms and engagement meetings. Do the messages from that filter down to the voluntary sector? And is that something that needs picking up?
Weekly comms and engagement sessions for which bit of the system?
So that's got the CCG, council and voluntary sector all there about messages that need to go out.
I mean, certainly.
Is that reaching the wider voluntary sector?
Certainly Ben has been sharing messages and information. I suppose I'm thinking about more than just comms now. It's about kind of more specific input to people who might have additional needs to kind of access so I mean, yes, we can probably make sure that that is robust, that system, but I think it's about more than just comms out to the general public.
Yeah, got you.
Okay, thank you. How about you, Jan? I think you are doing annual update on the Start Well.
Thank you very much, Mohammed, and I will endeavour to get through this at pace.
Great.
I thought that would go down well. I'm learning, Mohammed, I'm learning.
Right,
okay, right. So if we move on to the next slide, please, Wendy. Thank you very much. So you can see the Health and Wellbeing Board can see that we have refreshed our Start Well priorities. So the Children's Partnership Board, which is a subgroup of this board, has agreed 3 broad priorities to focus on an increased number of health and wellbeing issues for our children and young people and families. And throughout this presentation, it won't come as a surprise that we will be touching on the impact of COVID on our children and young people and families, but we'll also be referring to some of the issues that our children have been dealing with regard to their health and their outcomes more generally, which have remained quite difficult for us to tackle over a significant period of time. And that isn't to be critical of ourselves. I think that is just to reflect on some of what's already been said around some of the very specific challenges that our communities are living with, but some of the positive ways in which we can work with our communities and as a partnership in order to address those very specific challenges. So our Start Well priorities are poverty and neglect, emotional health and well-being, and adverse childhood experiences and trauma-informed practice. And as I've already said, all 3 priorities have been impacted by the COVID pandemic, which has disproportionately affected our most disadvantaged children and young people, families and communities. So we know that in Blackburn with Darwen, our child health profile in March 2020 highlighted poor health outcomes, and you can see those listed below. If we move on to the next slide, please, Wendy. I'm not going to go over this again. We do have our corporate COVID-19 dashboard, and that's available. And we also share this information on our website with our population at large. But you know that the detailed sit rep that Ken has given and Dominic has provided us with an overview does indicate that in Blackburn with Darwen we've had, you know, we have seen the biggest and most sustained impact of COVID in our communities, and that is something that is impacting on the health and well-being of our children. Okay, we move on again. So focusing on those priorities, we know that nearly half of Blackburn's children are living in poverty, and that's an increase. So, you know, from the 30% prior to the pandemic, it's gone up to just short of 50%. Universal credit applications. So during February to August, there's been a 63% increase in applications in Blackburn with Darwen, with a minimum of a 6-week wait for families. And then we also know from the data that we've got from our Help Hub, which has been sustained throughout the pandemic, although its remit changed more recently, 28% of the caseload coming in to the Help Hub has been from families in need, requiring support for food and essential supplies, access to personal and sanitary care, support with utilities and bills, and access to healthcare and medication, and mental well-being support. And as you, I think we've already, there's a presentation later on this evening, and Ken's going to lead that very kindly for us. But you know, our network of children's centres has been feeding 500 vulnerable children every week during the school holidays, but also we've had our holiday activity and food programme that was delivered during the summer, and actually to a lesser extent in the October half term as well. Again, trying to support families and feed hundreds of children throughout the pandemic. What we're going to do about how do we tackle poverty together? No mean feat, given I think some of the very specific challenges around changes to benefits and how they've impacted children and families most specifically. But what we're intending to do is that we will facilitate a stakeholder workshop that will be supported by the Child Poverty Action Charity to identify, you know, what have we got now and how we are responding as a partnership. Where are the gaps in support, to look at ideas and solutions and to action plan together in order that we can address the impact of poverty on our children and young people and families. Okay.
Yep.
So, thank you. So we've got neglect. I want to be really clear that that poverty and neglect, that there is an overlap, but just because a family is living in poverty doesn't mean to say that they are neglectful. Far from it. Neglect features in families who are dealing with multiple problems. Poverty can be part of that, but neglect often involves compromised parenting capacity to do with substance misuse, domestic abuse, and mental ill health or learning disability, all colliding together to impact on parents' capacity to appropriately meet the needs of their children. This is a significant challenge for us in children's services. 80% of the work that we do in the service, at whatever level, it involves working with children and families who are living with neglect. So it's a significant issue for us and our communities. We know as well that as a partnership, we need to do more to make sure that children aren't residing in neglectful situations for too long. So recognising what is neglect and how does it manifest itself is something that we've all got to get better at, including children's social care, in tackling the impact on our children and linking it to interventions, evidence-based interventions, which we know can really support families if they're done in a way that is early enough on in the child's life and in the life of the family as a whole. So the work that we've done and the progress that we've made with that, we did update our neglect strategy last year, but it's been relaunched in July with the support of the Children's Partnership. And we have already seen that this has led to a reduction in inappropriate referrals, improved identification and support, and better evidence of the impact of neglect from our partners within referrals. That doesn't mean to say we're perfect. We've still got further and more work to do. Some of that work is captured in our Neglect Strategic Action Plan, and that's been introduced to raise the profile and the impact of neglect, making sure that it's everybody's business. And then we've also developed a multidisciplinary Think Neglect booklet, which we're rolling out across our partnership. Okay, if we move on. Neglect Part 2. This is a key priority for the Children's Safeguarding Assurance Partnership. And as I say, we're also using an evidence-based tool, the Graded Care Profile, and we're rolling out that training and that tool to be able to identify neglect and how to respond and to support and work with families. We're implementing another batch of training and we'll be evaluating the impact of that. So you can see there the extent of the training that's been delivered, and you know, this is a hard slog, should I say, particularly at a time when we're all having to adjust the ways that we're working with regard to the impact of COVID. However, our next steps are we've got nominated neglect champions, and they'll be introduced to support the delivery of neglect and graded care profile training across our partnership. Okay, I want to say just before I move on to this slide and the content of this slide, a great thanks to colleagues in the CCG for their contribution through our SEND partnership board. We're doing some great work together, and I should have mentioned that Claire Richardson will be updating as in a later part of this presentation some of the impact of the work that we've been doing on improving children's health outcomes. You can see here that the Department of Education, the State of the Nation report to mark World Mental Health Day in October identified a worsening of well-being for children and young people during the pandemic, particularly for girls aged 14 to 15 and for children and young people with SEND. We are anticipating a 74% increase in demand for children's mental health services in Lancashire and South Cumbria. And, you know, we understand, having listened to our children and young people, that their well-being has been negatively impacted due to isolation from friends, having to learn from home, not being able to take part in the full range of activities, and also significant worries that family and friends might get sick and that they might bring the virus back home. And that is a massive, massive issue for our children and young people. And I think, you know, just it is something that we've all got to be mindful of. So over the last 12 months, the work that we've been doing together, so this links into public health, to our own service, but also through the focus that our colleagues in the CCG have been giving with regard to the impact and the effectiveness of the services that they commission. We have seen a continued investment in the Cooth online service, which is very well used in Blackburn with Darwen and evaluated as such. An increase in the Lancashire Mind Young Persons offer, additional funding secured to extend the CAM service to support young people from, so the age range has been extended to up to 19 now from 16. Support for looked after children. We have a fabulous internal resource with our Revive Emotional Health and Wellbeing service, and that provides therapeutic support and formal consultation led by a psychologist for some of our most vulnerable children and our cared for children. We've seen improvements in our ASD pathway. We've seen weekly family wellbeing webinars during lockdown, digital resources and support provided by LCAS, the mental health support team, implemented in secondary schools during 1920. And our school nurses and mental health practitioners joined our team around the school for the 10 school hubs that remained open for children of key workers and vulnerable children during the first lockdown. And we've also seen that a Pause for Thought and Childhood Resilience programme introduced into schools, although that has been a little bit delayed, as I say, because of the pandemic. Okay, if we move on. Health and Wellbeing part 2 is we've seen the implementation of our CAMS Trailblazer with our mental health support teams in our secondary schools. And as I say, they played a really key role in the lockdowns and in supporting schools and the full return of schools. We've seen the team in place since January 2020 with all of those clear processes and pathways to make sure that our children can access support earlier on, so they can access help and advice, or their teachers or school-based staff can access help and advice for children in school. So we are yet to see the full impact of that, but it's a really exciting development, as is the additional funding secured for the Trailblazer. Again, that was a partnership bid, and that Trailblazer will be rolled out into our primary schools as of September 2020. So we will have more work to do to evaluate the impact of that, but both really exciting and I think very necessary developments given some of the specific challenges that we've referred to earlier. Okay, if we move on. Okay, so we know that we are well informed about adverse childhood experiences and trauma-informed practice. We have continued to embed and build on that work, and that continues to be a focus for us in Blackburn with Darwen and for our partnership and the Children's Partnership Board going forward. Okay, if I move on again. So you can see we have a practitioner forum. We have online staff training that will continue to be offered to all of our Blackburn with Darwen schools. Virtual supervision is being offered to school staff to support their emotional wellbeing. And we've had the Wellbeing for Education return. So, you know, that's been about making sure that we are supporting and using the resources that we have to be able to mitigate some of the impact of COVID-19 on the mental and emotional health and well-being of pupils, staff and families. So again, you know, evidence of what Dom was saying about how we work collaboratively as partners and as systems in order to get the biggest impact on improving outcomes. Okay, over to you, Claire.
Thank you, Jen. Claire?
Thanks, Jane. And so really briefly, just some specifics on improvements in health services for children. So for years, we've probably wanted to do virtual health assessments, and COVID has meant that we've had to. And for some children and young people, that has been really, really positive. So certainly some of the lower level mental health, some of our outpatient type appointments we've been doing virtually, and children and young people have really benefited from that. We have continued with our face-to-face work where safe and appropriate, recognising that for some children and young people, they really do need to see somebody, so that has continued. We've done some reconfiguration of our acute paediatric services, which has supported pressure within urgent care, but has also meant that some of our delivery happens in the community, and that has been really positive again for parents and children, but as well for primary care and some of our more specialist services working more closely together. So that has meant improved relationships, but also the reduction of duplication and people getting seen quicker. We've put additional investment in the voluntary sector, speech and language therapy. So we know from our SEND report that we had long waits. We're doing quite a lot of work with speech and language services, and have brought in a national expert to help us find a way of reducing those waiting lists and providing more prevention and early intervention. Jane's talked about CAMS and ASD services. So we've put quite a lot of funding, but also resources into those services to support families and children during these difficult times. And are hoping to get a single point of access up and running for CAMS, which means that children and families will be able to self-refer. We have maintained and improved our response to children with special educational needs. So 100% of our health plans have been completed within the timescales, and we've improved timescales for health assessments for looked after children. So it's really important that we do those assessments quickly, and then we can get those interventions in as soon as possible. I'm particularly proud, as is Jane, of the work we've done around tripartite funding for complex packages of care. Blackburn with Darwen is the only partnership across Lancashire and South Cumbria that have agreed to fund equal split across health, education and social care for children. And whilst challenging, what that has meant is we are focusing on the needs of the child and the package rather than who pays for that package. So there will be some pressure somewhere in the system, financial pressure, but what it has meant is, again, our professionals are working more closely together. We are picking children and families up earlier, and that hopefully will impact on their positive outcomes. And I think particularly we've got strong partnership working anyway, but particularly during COVID, our joined up response has really strengthened our partnership working across our system, and examples of how we jointly check in on families to make sure that they've got everything that they need. I'll hand back over to you, Jane.
Okay, thank you very much, Claire. Thank you. And then we've got here an indication of our child health profile reporting in March 2020 and our outcomes risk assessment. So you can see where we are getting better, outcomes that haven't changed significantly, and there's a block in there that are particularly challenging to tackle, but some of the actions that we've already set out will hopefully do that. And it does say outcomes that are worse. So you know, our children in care, Mohammed, they are coming down, and so it does say that actually that data, the 105 per 10,000, which was accurate last year at this time, you know, as at 31st of October, we have a rate that is coming down and is more proportionate, as I would say, but actually does also reflect the fact that we are serving a vulnerable population and a young population in Blackburn with Darwen too. Okay, so next steps. Our corporate parenting board, our Children's Partnership Board development session in November has agreed the following. We're going to have a strategy and action plan, which I will report back on to the Health and Wellbeing Board. We have a task and finish group with a broad range of partners involved. We will develop a communication strategy to strengthen engagement with children and young people and their families and capture their views and ensure that we are focusing on the right things. We're going to be raising the profile of the needs of children and young people and their families within our 4 primary care networks, with an agreement to align our services into those 4 localities, and we are exploring a shared data mechanism across the partnership as well. So those are in order that we can assess impact of our collective action. So those are the next steps. Happy to take any questions.
Thank you, Jan. Thank you, Claire. Any question, comment to that presentation? Anybody? Don't see any hand.
Mohammed, mine's not really a question, it's just more a comment, if that's all right. Just in terms of the tripartite funding that Jane and Claire have worked so hard on, I think that's a real positive, and as they both have outlined it, with the only authority that's got that agreement so far, and I think that's testament to their work and commitment, but also I think it's just going to have a positive outcome, that we're focusing more immediately on the needs of the young person, and that's the whole aim of it all, isn't it? So I just wanted to say thanks for that, and that partnership working with health is really positive too, is most welcome. Thanks.
Okay, anybody else? No. Thank you, Jan. Thank you, Claire. Item 8 is COVID winter grant scheme again. Jen?
So I'm going to hand over to Ken just to give you a change.
All right.
But all I would say is that we were notified about the government agreed to fund the COVID winter grant scheme to support vulnerable households and children. I think we've got a lot to thank Marcus, given the specific challenge that he put into government, and I think made them change their mind alongside other representation, I know. But Ken, if I hand over to you, and I'm happy to take any questions at the end. Thank you.
Yeah, sure. Thanks very much, Jane. Yeah, I just wanted to say a little bit about the COVID winter grant scheme, and in Jane's presentation from the child development, obviously one of the key issues that was highlighted was child poverty, which is having a major impact on all sorts of things, particularly on food, accessibility to food. And it's an interesting conundrum that not only have we got some very, very high rates of childhood obesity, but we've also got some very, very poor levels of access to food in some of our communities as well. So when it comes to really addressing child poverty and the food, we're in a very, very good position, because we've got the Food Alliance, which Jane described, which has been working over the course of a number of years to develop to that point. So we're in a very good position to deliver this resource. So the COVID winter grant scheme is £170 million nationally. Blackburn with Darwen's allocation is 645,000, which certainly won't address poverty and the structural things behind it, but it will do things over between now and March to address vulnerable households and provide them with peace of mind over the winter months, particularly addressing food, energy, and all the things that go together to providing food and keeping homes warm over the winter. So it's to give vulnerable households peace of mind. We'll use a wide range of data and work that we've done already to identify those vulnerable people. The programme is going to work with the support hub that we've developed and honed through our work in providing support to people experiencing COVID, self-isolating and so on. But I guess one caveat is that the support's not restricted specifically to vulnerable households in receipt of benefit. So wherever possible, we'll use source of information to identify vulnerable households, but we'll also identify other households as well. So the grant allocation, at least 80% of it is to be ring-fenced to support households with children, with up to 20% of the total to fund other vulnerable households. 80% of it is to be ring-fenced to provide support with food, energy and water bills for household purposes. And within that, there's flexibility for the proportion of support to be allocated to food and bills. Up to 20% of that total funding can be used to provide support for other essentials clearly linked to the scheme conditions. So some of these that we've thought of already are things like sanitary products, warm clothing, soap, blankets, boiler services. So some of the basics, really, I think. and it can include things like the purchases of fridges, freezers, ovens, etc. All of the things that affect the household's ability to access food, energy and water. So that's pretty basic stuff, but in very, very short time, Beth Wolfenden and Maria Nugent have pulled together a very, very detailed plan. And Chair, the reason it's coming to this group is that it's a multi-agency and organisation partnership to deliver this in very, very short time to vulnerable households with children and others across the borough. So and the Health and Wellbeing Board is kind of the highest level governance for this. So we'll continue to bring reports on monitoring to this board just to keep updated. So what the grant is not, it's not going to cover payments of rent and other housing costs because they're not directly related to food. It's not also intended for the provision of general advice on managing debt or financial hardship. It's going to be paid, 50%'s been paid already. We've received that into our budget. So the council is acting effectively as the accountable body for this. 25% in February and 25% at the end of April. We can use up to 10% of it for administering the scheme, and we'll have to provide management information back on the work that we've done. So these are the indicative funding amounts. I won't dwell on these too long, but in relation to the governance, I think it's important that the Health and Wellbeing Board is aware of these, and I've sent the presentation to Wendy to circulate to the board as well. So the funding split then 80% on food and utility bills, because there are more families at home during winter due to self-isolation and furlough, etc. So there's also families who, because children are sent home from school because the bubble, there's a case of COVID in a bubble, so that means more time spent at home in the winter months. So there'll be increasing demands on heating, lighting and water. So it's an opportunity to relieve pressure on homes, and it's split into two halves, December to January and then February to March. So this only takes us through to March next year, and it's not a huge amount of money, but I think because of the existing partnership we've got, all the work that's been done, we're in a very good position to get the best out of it, and our partnership is working very, very well. So the key actions to date, then we've set up free school meals. Blackburn, for people on free school meals will get Blackburn with Darwen market vouchers. Those have gone to print already. We're identifying all vulnerable groups between 0 to 19. There's some work with care leavers. There's calls for expression of interest to the voluntary, the VCSF sector to provide support with the food element. There's a process for local organisations to apply for small grants to support local families. So a lot of this resource will go direct to the family, but some of it will go through specialist organisations and our specialist community and voluntary sector partners to deliver effectively. There's also a referral process for health and allied professionals to request support for the family. So those are things like that Claire Richardson was identifying in the previous slide, some of those additional support services for families and children. And then there's a confirmed grant scheme use. We've worked through our procurement team to make sure that we can get that grant out very, very quickly. So the key actions to date then is the weekly winter grant scheme project team is going to meet regularly to make sure that we've got an operational oversight of what's happening, that we've got a close eye on it. Also, that's going to meet every week. We've also already got organisations to support utility bills and essentials identified, and developing a pathway to make sure that people have got rapid access into that. And then there's opportunity for local food businesses to develop fresh food box schemes. So we're working with those local organisations to make sure that we can get food direct to people as quickly as possible to meet their needs. And then this is the list of key partners. It's a multi-agency, multi-sector partnership, including community and voluntary sector, Leading, Care Network and Healthy Living, the Jubilee Credit Union, Healthy Living in terms of the BME network, and then United Utilities are also involved as well. And then we've got a long list of other third-party organisations who are also committed to support. The next steps then, which we're virtually off the ground with it in very, very short time. So huge credit to Maria Nugent and Beth for pulling this together with partners very, very quickly. And I'd like to thank all the partners who've responded very, very quickly to help this to happen. And then to make sure that we've got communications out for members, partners and residents to make sure that they know how the programme is accessed, and our comms team in the council are supporting that in making sure that we're able to get messages out effectively to partners and to residents so that they can access the support. And I was trying to do that in 10 minutes, and I think I've just about managed it, so I'll hand over to Jane now if she's got any further comment.
I think, thank you very much, Ken. I think I'm really I just thought it was a great idea of and I don't know where it came from. I'm going to give Maria Nugent the credit, and apologies if I've got it wrong, but that idea that Roger has just highlighted about using the vouchers for our markets in order that we utilise the grant to support kind of business resilience as well, and I think also for families who perhaps don't go to the market, introducing them to the market as well as a place where you can get really good quality and reasonable produce. So, you know, I think that's it. You know, it's just one of the bits of the joint work that's been done that I think we should be collectively really proud of.
Great.
Anyway, thank you.
Thank you, Ken. Very positive news. Thank you, Jen. Anybody has any question, comments? No? Move on to any other business? Anybody? Next meeting will be 10th of March. So agenda item, if any partner is interested to put any agenda item, please get in touch with the department. Okay. Thank you very much, everybody attending this meeting. Thanks a lot. Good evening.
Thank you, Chair.
Thanks, Councillor Khan.
Thanks.
Thank
Thanks
you.
all.
Thanks,
Bye.
everyone. Good night.
Bye. Bye. Bye.